Researchers developed dry powder inhalers, or DPIs, in a search for an easier-to-use, more environmentally friendly alternative to metered-dose inhalers, or MDIs. Studies had consistently shown that the majority of patients had poor technique with MDIs. Poor technique decreases the amount of drug delivered to the lung and is correlated to poor asthma control. There was also concern that chlorofluorocarbons in MDIs contributed to the depletion of the ozone layer. As we will see, DPIs avoid some of the common technique problems with MDIs, but unfortunately, inadequate technique with DPIs is still very common. Instructing patients on proper DPI technique is essential in maximizing the drug effectiveness. So healthcare professionals should be able to demonstrate correct technique to patients. Although various DPIs are similar, there are some important differences between specific devices. So healthcare professionals should be very familiar with the features of commonly prescribed devices in their practice. The purpose of this video is to discuss 4 dry powder inhaler, or DPI devices. These include the aerolizer, handihaler, neohaler, and pressair. We will discuss the general mechanism of DPIs, summarize advantages of DPIs compared to MDIs, demonstrate the proper technique and outline the cleaning and storage of each device, identify common technique errors that limit the effectiveness of these devices, compare similarities and relative advantages for each device, pointing out important factors in selecting a device. The 4 devices selected for this video are all indicated and FDA approved for patients with COPD. Of the 4, only the aerolizer is approved for an additional indication of asthma. All drugs for these devices are long-acting and are dosed once or twice daily. 3 of the 4 devices use gelatinous capsules that must be inserted into the device prior to inhalation. The pressair device is self-contained, meaning the dry powder for inhalation is already located within the device. In its most basic form, a DPI is comprised of 3 parts. The outlet port is the mouthpiece, which delivers the dose to the patient. The second part is the air inlet port. Outside air enters the device through the air inlet port during inspiration. The patient needs to inhale at a sufficient inspiratory rate to disperse the particles into respirable size particles of 3 to 5 microns. Because it is the patient who disperses the drug particles and not the device, DPIs are sometimes called passive devices. The third part of a DPI is the drug compartment, or a drug-containing capsule. In addition to the drug, the powder formulation generally contains an excipient like glucose or lactose as a carrier substance. Glucose or lactose also helps to disperse the drug powder during inspiration into 3 to 5 micron size particles. This is the ideal size particle to reach and deposit into the lungs. Some patients may note a slightly sweet taste from the glucose or lactose. Although the amount of lactose is relatively small, patients who are very sensitive to lactose may not tolerate lactose-containing powders. All 4 devices in this video contain lactose. The pressair is an example of a reservoir device containing enough bulk powder for 60 individual doses. It has a metering mechanism to correctly measure each dose just prior to inhalation. The second type of DPI is a unit dose capsule device. Each capsule has a pre-measured dose that is separately packaged in a foil blister. One potential advantage of unit dose DPIs is the additional protection of the drug from moisture until prior to use. Moisture causes the drug powder to clump, decreasing the percentage of drug particles in the desired range. Drug particles larger than 5 microns are more likely to impact the throat or larger airways and not reach the lungs. The unit dose capsules may also provide a greater consistency in the measured dose relative to reservoir devices. We will talk later about the significance of the type of drug compartment on device storage and secondary expiration dates of reservoir versus capsule devices. There are several advantages of DPIs compared to MDIs. The first advantage is that DPIs are considered passive, breath-activated devices. As a result, DPIs require little coordination between the release of the dose and inhaling it. This so-called hand-to-lung coordination required of metered dose inhalers is challenging for many patients. The patient, not the propellant, generates the necessary force to inhale the drug particles. Because DPIs lack a propellant, there are less environmental concerns. Also, DPIs will not have a propellant aftertaste that some patients complain of. Holding chambers are not needed with DPI devices. Because patients receive a new device with each refill, DPIs require less maintenance and cleaning. Many DPIs contain longer-acting drugs that can be taken once or twice daily. Now that we have an idea of how DPIs generally work, let's discuss the optimal technique for each device, starting with the aerolizer.